as Dr. Fox said, Mary Siegel. I'm from the advisory board, and kind of a quick show of hands, relatively familiar with the advisory board? So half and half, just to give you the 2-second overview. Company that was born and raised 25, 30 years ago within the healthcare space. Started off as a research company. Over time, we morphed into a consulting division. We've created databases for hospitals. And today, what we're here to talk about is ICD-10 physician education. It is something that my team's been working on probably about 5 years now, ICD-10. And across the course of the 5 years, 2 ICD-10 delays, what we realized was we can't just focus on ICD-10, but we've got to figure out what is the biggest challenge for hospitals, and how can we structure a conversation that hospitals are going to get big rewards today. And so what we realized was documentation was about 85% of the ICD-10 risk. And when we started digging into that, and when we started talking to hospital executives, CDI teams, physicians, what we found was that there was not only going to be a big challenge to get the ICD-10 documentation that the coders are going to need, but there was a big challenge today in simply getting the right documentation to accurately reflect the patient acuity. And so that led us to talking to folks like Ashley, who are physicians and who have had a ton of conversations with other physicians about documentation improvement, talked to hospital execs, talked to CDI teams, and really wanted to understand how are the best hospitals across the country, how are the most productive conversations, what does that structure look like, who's having the conversation, what are they bringing to it? And so we started off on this project. It's called the Physician Documentation Initiative, so we might refer to it as that or PDI. And Victor and I have had many conversations on this in the past, so he's going to be your in-house expert. But we wanted to understand what are the challenges, and it really came out to be twofold. One was simply educating all of the providers across the hospital, and then the second was honing in on your high-impact providers. And so this is really the culmination of a lot of that work, a lot of the research, and a lot of the practices that we've been put in place with hospitals for the last 2 years. And so I brought with me 2 of my colleagues. I'll let you introduce yourselves both briefly, and you can talk into my mic here.
I'm Ashley Lowry. I'm an internist and practice palliative medicine. So I am clinical, sort of boots on the ground, and am here to give that piece to the presentation today. Thank you for having us.
Then we got Dan Schreiber over here.
So my role is a little different. My team helps manage all the work that the advisory board does with Cooper. So regardless of a project like this or some of the other research-based projects, it all flows up to us. So we have a team of really 2 people who work for me, and everything advisory board kind of flows through them, which makes it nice and very streamlined.
I don't want this to be a presentation. I want it to be a conversation. I've got you for, let's say, 50 minutes. I will promise to let you out early, but at the very worst on time, because I don't want to overstay my welcome. But ask us questions, interrupt us. We've got Ashley here so we can get really deep on the clinical and give you guys a ton of examples. And you may have to speak up because it's hard to see with that light. So I'm not sure who's going to be raising their hand or asking questions. So just to address the elephant in the room, ICD-10. Dan and I were actually just talking about it today. Is it going to happen? And all signs point to yes. CMS is ready to move forward. Testing is ongoing. Hospitals are ready. We have not seen anything really been put into legislation that has a chance at passing. And so the advisory board and our experts are really moving forward as though October 1st of this year is the actual date of the transition. And so what we realized is through the 2 delays and over the course of the last couple of years, we studied documentation and we wanted to look at what's the gap in ICD-10, but also what's the gap today. And what we found simply was there's a big revenue opportunity, and it's going to become even larger after the transition because of the changing reimbursement, because of the greater specificity, other challenges that hospitals are going to face. And so realized it was a big enough issue for our partner hospitals and for the advisory board to really figure out. And so, as I alluded to earlier, we found that there were 2 work streams of education that we found best practice across the industry. So the first is getting to all of the physicians across the organization. Everybody needs a baseline. But then the second is honing in on the high impact doctors. So these are the high volume, the difficult to work with. I'm sure the group in the first row here knows exactly who they are off the top of your head, but they're the doctors that they're queried on the same exact things day after day. They don't readily engage in a conversation about documentation improvement. And so thinking about the first work stream, educating all of the providers across the hospital, we studied a ton of education models, and we wanted to understand what do they have in common, what differs, and what do successful programs put in place. And what we found is there were four cornerstones, four hallmarks of these specialty-specific training sessions that were really able to turn the dial on the level of documentation. So first and foremost, and this was really important for the group sessions, it had to be physician-led. It had to be a peer-to-peer and somebody who could get really deep clinically. From there, it was focused on examples. So don't talk hypothetical, don't talk about theory, but give them actual examples. Focus on the concepts, not codes. So going back to how can you communicate with a physician in language that he or she is going to understand? Talk about laterality, talk about causal agent, don't talk about code 11202. And then the last is make it as customized as possible. So broad-based education is great, but if you can refine it to their specialty, talk to a neurosurgeon about their clinical concepts as opposed to something that an orthopod's going to have to incorporate was really important. So from the specialty-specific training, that's what we found had to be incorporated in those conversations, and I'll give you a couple examples. But more importantly, when we started digging into a hospital's data, we found that a small percentage of physicians were driving the vast majority of the opportunity. And so for Cooper, you've got CDI in place, just had your year anniversary. For hospitals with successful CDI programs, this is what we saw. It's not a widespread problem, but it's a very concentrated problem. And so these physicians, quite frankly, just needed a different approach to the education. And that's what we're really going to get deep in today and give you a ton of examples, really show you how did we see CDI teams, how did we see CMOs turn the lever with their physicians that fell into this bucket. And the challenges that we heard from them, you can probably add 25 to this list, but they don't care, what's in it for me, this is a government regulation. And so we wanted to get away from that, and we wanted to focus on the physician. And so this is where, if you've ever met some of the researchers at the advisory board, they sit on the 9th floor and they called us up and they said, Mary, we've got it. We've got sort of the magic solution to engaging a physician in documentation improvement. So we said, sure, what is it? And they said there are 3 critical components. So the first is it's got to be exclusive. And again, this is the group of 10 to 20% of physicians. You got to have one-on-one conversations with these docs. It's got to be all about them. The second is it's got to be built on data. These are scientists. They are data-driven. Don't talk to them about what's happening in Oklahoma. Talk to them what's happening in Cooper. Are you laughing because you've done this?
Sometimes, but we know the doctor.
You know that, exactly. It's not a surprise of who's the doctor.
I might be one of them sometimes.
Well,
Not a negative.
we were laughing earlier because a lot of the administrators will show up on the list and they'll say, this is why I went into administration. I couldn't figure out documentation. And then the third is it's got to be expert-led. So it's got to be clinician to clinician. It can't be somebody from finance talking to the physician, but it's got to be somebody who can really empathize with that doctor. And so this is where every hospital across the country is doing one of these. Everybody's doing some sort of mixture, but very rarely did we see a hospital do all 3 together. And so we wanted to figure out how do you bring all 3 of these components together in the same conversation. And so when you would have those conversations, would you say it includes 1 or 2 of these, all 3? How would you see those set up?
In terms of, well, so definitely physicians will respond more to somebody who actually knows what they're talking about, has that expertise. It does matter, but exclusivity for some people is going to be the big thing. I mean, you have to have somebody they respect that they know they can communicate with. So, Nicole, that'll be your new role.
Right.
Everyone. But that trial does work. Right? How many, you guys have done studies on this in terms of 80%, you think is the number that'll hit most people?
So we've done studies. 85% of the risk in ICD-10 is documentation related. So that's coding, take-backs, under documentation. But then within this, kind of the physicians who you need to invest the extra dollar in them, we would say 10 to 20% of the physicians would make up 80%.
So when you say evidence, you also
So the
and a lot of
evidence,
it's going to be that follow-up. So that one-time session won't work if you don't stick. So it's not what you expect, what you inspect, right? So if you don't come back to those people or actually everybody and say, here's how we're doing. Is that part of that evidence part?
So what we would actually suggest is you not only give them data from in advance of the training, but it's not 250 doctors, it might be 20 doctors at a place this size. You actually track them for the next 3, 6, 12 months after the training and just show them their trends. And what's that? Individually, they're
Departmental, you want to look at the group, department, but
Yeah.
that
We'll give them a
trended
benchmark.
data over time, that's trend identification. That's the ongoing feedback on how you're doing and what's happening. That does
Exactly.
make a big difference, especially when you go show outliers.
Right.
So someone might think they're not an outlier.
Well, all of them think that they're outliers and that they have the sickest patients,
Right, but they're documenting.
but their documentation doesn't show that. And so, and I'll actually give you examples because these conversations can take a couple of different forms, and type of data that might work for one physician isn't necessarily going to turn the lever for another physician. And so part of it is also tapping into these resources here and figuring out, okay, what does Dr. Jones respond to versus what does Dr. Roberts respond to? And so what I have here, so here I'm going to show you a few examples of kind of what this looks put into place, and interrupt us, ask us questions during this, because I think this is really where we're going to get a sense for what do the physicians see and how does their behavior change. But just to recap, so the two work streams, specialty-specific training and then individualized, very targeted training. And one thing as we track towards October of this year that we realized was going to be really important is understanding where does your organization fall in advance of the transition, and also how are you performing post-transition? Because there's going to be a ton of change. You're going to be able to benchmark internally, but my sense is externally benchmarking is going to be a big challenge for hospitals. So I'll give you a few ideas of what I've seen, what people have put into place, and what I think is going to work really well. But for the specialty-specific training, to kind of recap, you want to break it out by specialty, fill it with examples, fill it with the clinical concepts, not the codes, have folks like Ashley teach the sessions. But the most important part of any of this is simply getting the physicians to the table. If you guys were to have a training session in a couple weeks, would physicians come, or is it mixed batch?
So we did specialty-specific training already for ICD-10. But that's what we do that at a place like Cooper is offered online. Honestly, you're not going to get one-on-one schedule. There's a huge, we have over 500 of
Yeah,
those.
it's mandatory, we track it.
We mandate
And
it.
so they get 100% completion of these kind of education sessions.
And it was, as you said, chock full of examples, specific. They could do it at their leisure. But I think if you just had, even to get a session like this together to determine who the audience was tricky, just to figure out who could come and who couldn't come. But to get all the doctors in one specialty at the table, I think it would be overwhelming.
And yeah, I know we even had to push it out a couple weeks to get the right people around the table. When I think about getting the people around the table, I would say it's something that has to be planned many weeks, if not 2 months in advance. And so one of the things the advisory board's created, and I can send you guys in follow-up, is a communication template just of how often do you reach out to physicians, who's reaching out to them, what are some templated emails that you can share with them, and really in the hopes of getting them to understand that this is a big investment in the providers. You want them there, you want them to participate in the training, and then making sure that it's going to be on their calendar and not double booked if possible. And the other thing is, in person, we found helps from an engagement standpoint. So providers tend to take much more away from an in-person session than an online, but you're always going to have physicians not be able to go. So doing something like this where we're recording it, doing a teleconference, maybe doing 2 or 3 sessions for orthopedics if you've got a ton and it's just not realistic for them to come to the same session. The folks that we put on our team at the advisory board, because we were trying to think about, okay, well, who's the right group to staff this? We wanted 2 common trends with all of these people. So the first is they're clinical experts. And we have a mix of both physicians and clinicians because we realize there's no one right person for every hospital. The second is they're incredible communicators. And when you think about all of this documentation improvement, it comes down to how effectively was it communicated and did the physician understand what they were being taught. And so the last piece of really ensuring that across the organization you're on track for ICD-10, and then post ICD-10 you have a laser-like identity into who are the physicians, who are the service lines that are really lagging, who is not documenting as well as you need them to. And what we realized were hospitals were not going to have great benchmarking data. And so what we're doing at the advisory board is we've got, I just read that 60%, I thought it was closer to 40, so I've been under promoting it, but 60% of inpatient volumes flowing through the advisory board's tool. And so for hospitals starting in October through the end of the year, we're essentially going to create weekly benchmarks so that you can see on a regional basis, you can see across the nation, you can kind of slice and dice the benchmark how you want. How do you compare to your peers? So that there is some sort of external benchmark, because when I think about the ICD-10 transition, and I think sort of about, let's say I get a 5% raise and I don't know what inflation is and it happens to be 7%, it's like you took a 2% pay cut. And so when you think about ICD-10 and case mix index, if your case mix index jumps a little bit after ICD-10, you want to understand as a hospital, is that the new normal, or did we actually perform better in a post-ICD-10 world? Has this group thought about how you're going to be benchmarking?
Post ICD-10. We've thought about it. Yeah, I don't think we've defined their metrics yet, but we're just trying to get them as well.
You're trying to make it to it.
Yeah.
Certainly. All right. Well, the second work stream, and I think this will probably stem a little more conversation for this group, is how do you hone in on that 10, 20% of physicians who are driving the vast majority of the opportunity? And once you get them, what do you share with them? And so I know you were laughing that you already know who they are, but thinking about data, you want data to validate that. And we were talking a little bit earlier about the issue with attribution. So the data is not going to be able to tell you everything. How do you work around that? And so what the advisory board has done for hospitals is we realize you've got to look at the data in two spheres. So one is from a revenue standpoint. What are the areas that are lagging the benchmark? Where's your case mix index lagging? Both on the national benchmark and also a regional apples to apples benchmark. Pull out all those cases. From those cases, where are their quality outliers? Because the revenue is not going to tell the entire clinical story. So where might severity of illness be low, risk of mortality be low, but length of stay is high, patient age is high? Where are unspecified codes used? And essentially what folks do, and this is Ashley's, where she starts to get really involved, is look at all of this data, pull out the cases where there's a financial opportunity and a quality opportunity, and try and identify, okay, is this an outlier case or is this a real documentation opportunity? And does this warrant a second look? And so from all that, look at it on a day-by-day basis and make rosters of physicians and say, here are your biggest financial outliers, here are your quality outliers, here are your top queried doctors. CDI might create a list of here are difficult to work with physicians. And if we can inflect a behavioral change with these guys, that would be a tremendous help. Create rosters and then identify, okay, who's on every roster? Who's on 3 or 4 of the 5 rosters? And really figure out who are the physicians that fall into that 10 to 20%. I would say most hospitals can come up with, if they think 20 is the right number, they can come up with 10 to 15 doctors, but there are always about 5 to 10 doctors that are a little bit of a surprise, and sometimes they hide behind the data. And another thing I put here is, you might not only be looking at opportunity in today's documentation, but you might be looking at what is the risk associated with ICD-10? So do some of these physicians have a tremendous number of codes that are changing? Do they have mapping risk? And are they going to have to include new documentation? Do we want to work hands-on with them so that in October the world doesn't flip upside down? So once we create those rosters, those lists of physicians, the next step is to do chart reviews. Because as I said, data doesn't tell you everything. Attribution is an issue. And the only way to really understand who wrote what, who should have written what, who could have written what, is to do a chart review. And this is where, for these providers, since we've already done such an intense data analysis, we pulled 10 charts per provider. 7 to 8 have documentation opportunities. And we actually look at them from was this coded correctly? And was this documented correctly? Because what we found with physicians is you have one shot to have this conversation. And if you bring something to them that was, had a coding inaccuracy, which only happened about 1 or 2% of the time, you immediately lost them. And it was really hard to recapture their attention. And so doing these chart reviews, figuring out what are the common themes, what are the trends that we're seeing across their documentation, and what are the 2, 3, 4, 5 things that we want to teach them that are going to get them to capture their patient's acuity. It's going to cause fewer CDI headaches. Coders are going to be able to do their job, and it's just going to keep the engine going. So I'm going to jump into what this education looks like, but any questions or any thoughts about how the process takes place and how the preparation takes place?
Is this program also, or does this model work a lot with the residency program also? Fellowships and things like that?
So for residents, the challenge again is within the attribution and who's actually doing the documentation. And so what I would say is that has to be a heavier lean on your CDI team to really understand who are the residents who work with which physicians, who's really the one who's doing the documentation, because what we found is oftentimes there were residents that were the challenge. And so for big academics, we'll create resident onboarding programs where the first 3 months we're in front of the residents about 3 times, and then for the remainder of the year, you're in front of the residents about once a quarter to just instill those good habits. Unfortunately, they don't get them in medical school.
So one thing we have done at Cooper really is try to tell physicians that regardless of the residents, they have to documentation. Okay, so we've targeted the physicians at an attending level that we don't query residents for the CDI process for a reason, because I think there's so many variables with that and so many things that they have going on that we do teach them lessons in orientation. We try to make the message relevant, but really at an attending level, I think you have to get them to openness because that's where it hits them, individually, and they understand what drives the hospital.
And we, so this is kind of this upside down triangle of the roadmap of the conversation, starting high level, going into their specific data. The first thing we talk to them though about is the publicly available information. And so I will preface this by saying in 5-10 minutes, we're gonna go through what takes place across the course of an hour. So this is very abbreviated, but there are a ton of physicians who have never looked themselves up on the internet, don't know their health grade scores, they don't know what quality metrics are being reported to them. There were physicians that we were actually working with in the state of Connecticut that got cut from their plan because of their quality metrics. And it was 2-year-old data. Oftentimes it wasn't actually reflective of their documentation, other people were doing it, but it was getting them to care when a case is attributed to them. This is actually a reflection of their work. And so this, I would say, you have so many of these conversations, probably is one of the biggest areas that gets a physician talking. It's not yet education on the words they have to use, but it's giving them a sense for why is this so important? Why does your documentation matter? And it lights that competitive flame within a physician.
Yeah, this is at the beginning of that discussion and sort of trying to, the engagement part of it and just having a conversation. And sometimes, we'll bring up an article that was recently published about quality and across health systems and just kind of tuning into what is interesting or sort of the hook for that individual physician. And building off of that and then getting into that conversation about this is 2-year-old data that we have, and the best way to impact moving forward is to start today. And really not even sort of waiting for ICD-10, but these are all because we're teaching and helping them learn concepts, not codes. This is stuff that they can put into effect right now, and they don't have to wait till October. And so it makes it a little bit more kind of real for the docs.
Mm-hmm. We've got a physician who always starts this off by saying, when's the best time to plant a tree? 20 years ago. When's the second best time? Today. And that's sort of the data is reflective of 2-year-old data. But if you want to make changes 2 years from now, you got to put that change into effect today. From there, we actually realized that revenue is not necessarily driving a physician to change their behavior, but it can't be ignored. Because too often we heard from physicians, we interviewed hundreds and hundreds of them, why are you against these CDI efforts? Why are you against documentation improvement? And the number one answer was it is revenue driven. It is the hospital is out to get more money and I'm getting less and less money in my pockets. I'm just trying to, scrape by these days as a physician. It's not what it used to be 30 years ago. This isn't my prerogative. And really what we had to talk to physicians about was this revenue, the quality, it's actually impacting you as a provider, and hospitals are going to see up to a 6% penalty because of quality metrics, because of reimbursement from value-based purchasing, readmissions, and hacks. And that's going to impact you as a provider. And to be a good steward to the hospital, this is where we found physicians would really understand, gosh, the hospital, this could wipe out their margin. As you look forward into professional reimbursement, what that's like 5, 10, 15 years down the road, hospital and physician reimbursement is becoming more closely linked. And so folks really have to get in the boat, they have to row the same direction, or they're going to be spinning circles. There are some hospitals where they actually want us to take this out. And so if you don't want to talk about revenue, we can ignore it, but we found you better call it out because the physician's going to want to talk about it. I see some nods. Have you guys talked about revenue before? What is the reaction?
We don't, the CDI team does not. We don't talk about revenue. We know it exists, we know what impact we do, but we don't make it a money issue, we make it a quality issue when they have our conversations.
Do you
But I
think that
have been asked about, you're always trying to diagnose. I've had that. I said, well, what are you treating? You know, let me know what you're treating. So, like that problem.
do you think the physicians, if you asked them, would know what Cooper's margins are?
A lot of them would, not all of them would. I think the thing with revenue, I just presented to the general internal medicine group this morning about the impact the CDI programs had on them, making specialty specific, and I blanked out the financial, the revenue recovery column because I've been asked to by compliance. But I do kind of share with them, we left about $12 million on the table in the last year and a half that we recovered through the CDI program. I think those numbers are important for them to hear just so they, more from a shock perspective, that you could leave that money on the table, but you're taking care of the patient anyway, and those patients had that diagnosis anyway, and it's just money that's kind of left there because the documentation didn't reflect it. That's the way they respond to the message best, and it doesn't make it appear, it has nothing to do with the hospital trying to make more money, it just has to do with recovering money that was already there that you weren't taking advantage of because your documentation wasn't appropriate. So that's the way I deliver the message, and I think it negates that you're just out to make money. No, we're just recovering stuff that was already there, but not being recognized.
Yeah, absolutely. And a lot of physicians, would you say your physicians know things like SOI, ROM? So a lot of physicians don't. Those are such critical terms, though, to understand why is documentation so important. So I took it out, but kind of right before here, there are a ton of terms that CDI teams use on a daily basis. Physicians are never exposed to, but relative weight, length of stay, severity of illness, and so on, and really sets up the platform for what are these, and then we kind of go into, okay, why is it so important? And I don't know if you want to present.
As we're funneling down, kind of becoming more and more specific in that conversation, that when I sit down with the other physician and have that conversation, this is getting that one step closer from the broader picture into actual first example of clinical documentation that we review. This is a generic example. Same patient, top half of the screen, lower half of the screen. Top half of the screen you can see here, and we try to highlight kind of the take-home points here. You see symptom, and then a principal diagnosis, and then elderly patient came in complaining of back pain, has a compression fracture at L5. Then, so same patient, bottom of the page. Actually, as you just said, you set me up nicely for this. What's the diagnosis? And trying to get folks like me that are taking care of patients to understand it's the same patient. We don't want you to write more words. We want you to write the most specific that you can, and talking about probable, likely, suspected is okay. That's great in the inpatient setting, because I think there is some hesitance to, well, I don't want to give a diagnosis if I'm not sure that's what it is. I don't want to sort of be inaccurate in my documentation and striving to be as specific as possible. So having a conversation around that and giving this is the first kind of specific concrete examples that I go through with the other physician, and then you can see the gray boxes on the side. This is like one of my favorite slides, because it talks about at the top here how these couple of changes, being more specific, not more words, just sort of kind of more precise words, completely can change your DRG bucket that the patient gets put into, and because of that, the relative weight, length of stay, all these metrics. Again, not a vocabulary or a lesson for them, but the difference in seeing that, wow, this is the same patient. I'm taking care of a sick patient. I'm providing great quality care, but my length of stay can go up, my severity of illness, risk of mortality, just from these few changes in the documentation.
Do we have anybody from case management? No. When case management is part of the conversation, when case management is part of the conversation, oftentimes this will be the aha moment with the physician saying, okay, now I understand why the hospital wants me to discharge my patient on day 3 when I think that they should be in the hospital for another day on day 4, because you're not capturing the right severity. You're not capturing how sick this patient is, and suddenly the right documentation is it's communication with case management, it's communication with CDI, with medical director, and so on. And it just really opens the door to how does a coder do their job? How do I as a physician do my job? And why are these words so important? From there, one of the things we share with the physicians is how does your specialty compare to your peers? And so what you've got on this page here is, let's see if I can find my cursor, 4%, this is the hospital, Shady Brook, the pseudonym, 4% of their major joint replacements are picking up an MCC versus regional is 9% and US is 8%. So it's sharing with this physician, you're capturing how sick your patients are half as often as your peers are across the country. This was a referral center, so clearly they had much sicker patients than these other folks. And so it's asking them why, and it's starting to lead the physician down the path of you're probably contributing to this 4%, and so what's going on within your documentation. That was a high-level hospital overview. We want to then give the physician a high-level overview of their world. How does their severity of illness compare to their peers, their risk of mortality, their length of stay, and so on. And then from there, jump into specific examples. And here is, when I mentioned we do about 10 chart reviews per physician, 7 to 8 have learning moments. This is one of the charts that we'll pull, and I'll actually have Ashley walk through much more eloquently than I can.
So now we've funneled down from broader landscape into regional data, service line data. Now this is the physician's specific chart data. Oftentimes they remember this patient as we're going through because it's been within probably the past 2-3 months that this data has been pulled from the chart. And so again, on the left hand side, it's a quick chart summary. It's just that kind of 2-minute, 2-liner blurb about the patient. Again, 80-something-year-old from the nursing home, hip fracture, had ORIF done, came in, then had sort of a complication from what ended up being congestive heart failure. Talks about there was really no associated diagnosis attributed to this patient to explain why the patient was getting IV Lasix. And then on the right-hand side, this is documentation examples from essentially when the patient appeared on the doorstep, from their problem list, from the ER, H&P, all the way through some diagnostics, down through progress note, and even discharge summary at the bottom of the page. And so it's all these hints to the patient has CHF, and this was a CHF exacerbation, but it wasn't ever diagnosed. It wasn't put into the chart. The patient was treated for that. They were assessed and cared for that diagnosis, but it wasn't actually put in the chart. And then for this patient specifically, it becomes important, thank you, because this patient actually died in the hospital. And so the physician always remembers those patients. And so we walk through, again, sort of comparing kind of two parallel worlds, the observed versus the potential for this patient. Again, same patient, same, really good quality care that the patient was getting, and trying to help the physician understand how they can accurately depict their patients so that they get credit for that care and they get the appropriate quality metrics attributed to them for the care they're providing. So you can see here, the principal diagnosis was the same. Secondary diagnosis changed quite a bit. Then resultantly changed the DRG, the relative weight, length of stay in this manner you can see here. And for this patient specifically, because the patient did die, you can see that the risk of mortality went from a 2 to a 3. And so talking about that observed versus expected risk of mortality for patients, and helping the physicians understand that when we accurately reflect the severity of illness for that patient, all those other metrics are gonna fall in line and better reflect that this patient died because they were really sick, not because of the quality of care that they got, but just for how sick the patient was.
And one of the other things that I would just chime in here is the physician's eyes at this point, they dart to these bottom boxes here because they've just been told what is relative weight, what is risk of mortality. There are 4 levels of it, and oftentimes a physician's going to see a patient who died and they're going to say that was an extreme. How did it code out? How's this reflecting me as a physician? And then I think one of also the big messages here is we're not changing anything about the medicine. We're not changing how the physician and the patient interacted, and the principle of diagnosis is the same. We're just trying to figure out, were there complications that weren't caught? Were there other areas that should have been raised within the chart, and maybe they didn't flow through the entire chart, so it couldn't be coded out. And for a patient who initially looked like they should be at the hospital for less than 5 days, is now almost at about 7 days length of stay. So I mean, there are pretty extreme changes here, and you want to go through about 2 or 3 of these with a physician. And what we found is 2 or 3 is really the threshold of giving them enough examples to get them to understand what are the changes, but not burying them in data. Because these charts can be hundreds and hundreds of pages, so we want to pull out what are the critical components of each chart. Were there examples of when the physician should have written something versus somebody else, and the physician just didn't, capture the consultant's notes correctly? And what we want to do from the 10 charts that we did, we're pull out a couple themes. And so this is where, when we talk about the sustainability, how do you measure change? This is something where the advisory board realized we don't want to set up office space at a hospital. That's not really the business that we're in. We want to help hospitals understand where is there the opportunity, and we want to help them hardwire that change and sustain that change. And so these themes, so assess diagnoses, not descriptors, kind of to your point earlier, physicians got to diagnose. These are the themes that we leave with pretty much this room, so that if 2 months later a physician forgets to include specify the weight-bearing surface, this is the group that understands what were the 3-4 changes that we wanted Dr. Baker to include in his documentation, and we're going to help him or her sustain that change. From there, we also, because we realized ICD-10 is so pressing, we wanted to include a few ICD-10 specific examples, but throughout this entire conversation, it is ICD agnostic. And that's very intentional, because what we heard from physicians is a lot of skepticism around whether or not the transition was going to happen, and they didn't want to know what they had to document today and what they had to document tomorrow. They wanted to know, what do they have to document? And so during the whole conversation, what we do is we teach up to that ICD-10 level of specificity without distinguishing what do you need today versus tomorrow. And then kind of towards the end, leave physicians with, we call them tip cards, or sort of the critical clinical concepts, but what are the clinical concepts that we saw that were going to be most needed for their documentation, and just make sure that they have a sense for what are the volumes of those clinical concepts. This is really going to cut down on queries. It's going to cut down on folks chasing you down the hall asking for more specificity. And so that is an overview of the training materials. And as I mentioned, it's an hour-long conversation. We ran through it in about 10 minutes. And it's an hour-long conversation, but we spend about a week preparing for it. We spend 40 to 60 hours mining through a physician's data, reading their charts, marketing this to them so that they're going to show up, and they really understand it's not a call to the principal's office, but it is an investment in that physician. And the only reason that they're chosen for this type of training, this individualized one-on-one training, is because they're really important for the hospital. So if this is a physician who's going to retire in 2 months, probably not appropriate for this type of training. If it's a physician who may not have shown up in the data, but they're taking on a bigger caseload and they're taking on more responsibility in the next year, you might want to get to them early and do this type of training. So I know Ashley and I have talked at you probably more than we wanted to, but would love to just open up the room and kind of see what your thoughts are in this training, how it differs, how it's the same.
When you say you would do something in 1 hour, do you mean that 20% of physicians you would meet with? So if we have 500 employed doctors, or however much, you would meet with about 50 docs?
So I ran, and it is a MedPAR analysis, so take it for what it is, it's 2 years old. But for the hospital, I think it recommended about 20 physicians.
For this hospital?
Mm-hmm. That's something that we would have a conversation about. Really, what is the area of diminishing returns? Because a lot of the conversations we'll have with hospitals, we St. Joe's, I don't know if anybody was on this web conference, but they talked on Tuesday about their experience training their doctors. They did 19 to 1 ROI. And for 15 doctors, I think they recouped over $3 million of revenue. And they said, even if we had gotten a 15 to 1 ROI or 12 to 1 ROI, we're going to do more doctors that we keep going after that. But we can certainly have a conversation about, is 50 the right number? Is 20 the right number? Is it somewhere in between?
I think that Question for you, because I did go to that, I was on that St. Joe's WebEx. And not to toot Cooper's horn, but I think we've had a tremendous amount of success with the CDI program, more than most hospitals probably have. We have a 100% physician response rate to it, revenue recovery has been significant, CMI shift has been significant. So that, all that legwork is done. Now I'm at the point where I'm struggling is how to take it to the next, how to sustain that change. You know what I mean, and make it relevant to the physicians. Maybe it is that we pull from our CDI database the top performers or the bottom, you know, whichever way you want to do it, or the bottom performers, and target them going forward. But how to sustain that change, because the points you're making are very valid. Physicians don't want to know, they want to know concepts, they don't want to know codes, and they want to know about what their performance is, but I'm just struggling about where to focus our efforts. Like, we'll keep doing what we always do.
And just to add on to that, most of our docs are aware that this affects their quality scores. There's a lot of information about quality, so they understand that this affects quality, revenue, and their reputation. It ties together in many, many ways. So there already is that platform that's been well done.
Right. So do we pull names every 3 months and focus our education efforts? Like, what's your interval and how do you do it?
So what I would suggest for hospitals right now is there are probably 2 really critical periods to pull names. One is now, kind of where are they documenting poorly today, but then the other is I am strongly urging hospitals to do this type of assessment in November or December. Once you've got 6 weeks of data and you can really understand, are there physicians who either are leaving out documentation and missing a ton of revenue, or another concern is, are there mapping shifts? And so you were get paid $15,000 for a procedure, and just based on the DRG, the code breakout, you're now getting paid $5,000 for that procedure, $10,000 swing, and it could be hundreds of thousands of dollars of missing revenue. And it's not because of documentation, but it's because essentially of the business that the hospital has. And so that's not going to be a documentation effort, but that's going to be we need to know this information so that we can understand where to expand and where to contract our business. Yeah.
I think it's more from our organization there than you, but the hard part we've been hearing more so is the ambulatory side and what's going to happen and how different is it. And I don't know that we've attacked that the way we probably intention, because we got moved back a little bit. What's our plan? Do we know?
Art was here. Our plan would be, you know, maybe Art can speak to this as Deputy CMO, but, you know, we wanted to have something parallel on the ambulatory side, one being a medical director for an outpatient type of CDI program. We've already identified someone we think would be appropriate for that. We haven't moved forward yet. 2 would be, we have a physician educator on the outpatient side, which would be Gail Rounds. And then 3, do we have, to have the type of program we have for the inpatient on the ambulatory side, it would need like 46 of me and like God knows how many CDS specialists. So I kind of just sent a proposal to Maz today about what I think it should look like on the outside in a streamlined version. One of the ideas I had was that potentially we could have 3 or 4 CDSs that kind of go, you know, we identify that areas for high opportunity, however we do that, whether it's the offices that see the highest acuity patients, or whether it's you know, the people that struggle with that bill lower than they typically should based on audits. And then we send the CDSs to those practices for, like, say, a period of 3 months. So it's like a Mary Poppins. They come in, they kind of clean it up, and then they go. They can probably target 4 specialties within a year doing it that way.
Okay.
That's one potential idea, but we haven't really, you know, formally defined it. I don't know if you have any more insight.
One thing I would offer up is we have created specialty for the inpatient and for the outpatient. And so I know that I think it's something like 85 or 90% of hospitals have inpatient CDI programs, about 4% have outpatient CDI programs, and it's just because the revenue, it's not always there. And so what we found is specialty specific, a lot of that's going to be over the web because physicians are going to be in different locations, but we've kind of templated all of it. And so we can we've set up ways where advisory board physicians will teach over the web and be in some locations, or we've actually equipped folks from the inpatient side to teach the outpatient.
To me, I think, maybe you can correct me if I'm wrong, in the outpatient setting, I think the 2 keys would be, 1, to maximize the EMR as much as possible for the physicians. Like, how can we do that so that, you know, they're spending more time seeing patients, and a lot of it's embedded in their documentation already. And then more focused education, you know, in the office, like somebody actually there with them for a defined period of time reviewing charts, and hopefully then they get it and we move on to another.
Right.
That's what I see. If anybody has ideas for how they think it could look in the outpatient, I'd love to hear them.
I think you're right about the EMR, but we need the workforce to devote.
Correct. Yeah, absolutely.
to redo it. And are we kind of out of time now? I mean, October 1st is kind of critical at this point, but for ambulatory, because it's been kind of behind the scenes, are we running out of time? Do we need to do something different now in the interim? Or?
I don't think so. I think, like you said, the seeds have been planted. All the ambulatory providers have received the documentation improvement education in the ICD-10 module, so they already have some foundation. I don't think it's ever too late to start. You know, what are your thoughts on that? I mean, I don't think there's anything we need to hurry up and do right this second.
Okay.
Especially not knowing exactly when ICD-10 will be implemented. Do we think it is? Yes, but you know, there's another push now to delay it again.
Okay.
So I think we just keep on the road that we're on. You know, we're preparing pretty well.
I think it's also how do you want to roll out the education? Because we were having a conversation with another group and they said there are 20 Mondays between now and October 1st. And that is, and I was like, oh my goodness. Exactly. But that is when they have their education. They have Monday morning meeting and they thought there are 20 of these and we've got to figure out how to get 10 of them for ICD-10. And so it's, you know, if you've got standing meetings, if there's dedicated time, and then making sure that when you've got that time, you just make the best use of it and give them what they want to see. Yep. Any other? The back group has been kind of quiet over there. I can't see you, but.
Quiet.
Yeah. I mean, with same concern about ambulatory. I mean, but we'll work it.
One thing to add, and I haven't talked much about this, for the one-on-one training, what we would highly recommend is you hone in on those physicians based on hospital benefit, because that's where the biggest dollars are at stake, but you teach their outpatient documentation well as well. And so when you're talking about their E&M, when you're talking about the codes that are most critical for them in ICD-10, I took out the pages just to focus on some of the bigger examples, but that's something that's included there. And so when you think about getting to some of the most vocal doctors, and I know that Mike Redmond talked a lot on Tuesday about this water cooler effect of they had these vocal doctors, they were talking about documentation, they were running away from CDI, and then suddenly we had these one-on-one conversations with them and they were our biggest champions. They were coming to us, asking us for help, and he talked about this ripple effect or the water cooler effect. That is also something that we've seen of if you're having a tough time getting to the providers, by incorporating their outpatient world in this, it really helps get to the what's in it for me.
I think that's another one too, John. Like a lot of those, for example, your neurosurgeon, they're used to the inpatient CDI certification, so they also need help on the outpatient side. But you need to take advantage, same with the surgeons, you know, surgical institute, like we need to take advantage of that. You know, but they're already used to the concepts and the ideas, but how do we translate to the outpatient?
But there are a select number of physicians that don't set foot in the hospital.
Correct.
And so they've never, ever been
That's right.
exposed to it. And there are many physicians that have a very, very limited hospital experience.
Right.
So they've not had the feedback because they don't do it enough. And so that number starts to get bigger and bigger, and the issue of the volume of patients that they see is potentially larger than the number of patients that are sitting in the hospital. Maybe the revenue is not equal,
Right.
but
Still important, yeah.
it's significant.
Yeah, and then just to throw one more wrench, the age of the physician, because you talked about optimizing, capitalizing on EMR, which is already like.
And I didn't mean by making them do it, but like we've embedded malnutrition information in our progress notes here, so the physicians don't necessarily have to document it over and over again. The dietary consult gets pulled to the note, and that diagnosis shows up without the physician having to do anything. So if they forget to document that the patient has severe malnutrition, if the patient does, it's already in the note.
Right.
So things like that, which actually may benefit the older physician,
Absolutely.
you know, in that sense.
Yeah, I would say that there's definitely a discrepancy in age of how we see physicians react, and so that's why Ashley has worked across the spectrum, and there are different plays for different physicians. Some want paper printout of their tip cards and their themes, some want them texted to their smartphones, and then others, they'll build it into their EMR and say, okay, for Dr. Smith, I want my drop down. So we have about 5 minutes left, and I will, I think I promised to let you go on time or early, so hopefully I can let you go a few minutes early. But I want to thank everyone for joining us today and leave you with, this is called the Physician Documentation Initiative. It is really for hospitals who, you've got CDI programs in place, and I think of that as the back end and kind of the reactive. We've got to make sure that we're catching the revenue that would otherwise slip through the cracks. How do we get to the front end or the point of the physician documenting onto the charts and really get them to have behavioral changes. So that, and I think about if you're constantly querying on sepsis, that 6 months from now, that's not going to be your number one query anymore. And so that you're constantly evolving. And that is really where, when I see how does this fit with CDI programs, it gets at some of those challenging physicians to continue the CDI program, quite frankly, to make a ton of progress and advance. So Dr. Fox and Jennifer and I have time later. I would say give me your feedback, give them your feedback, but would love to know if you're interested in this, what it will look like. I can give you more information in terms of what's the timeline around this. I can introduce you to more folks like Ashley so you get to know the team and you get comfortable with them. But I appreciate your time, and I'll hang around for a few minutes after.